Good afternoon. I'm Felecia Wood, and I'm glad to be here to speak with you about this project. This project is part of a larger project about chronic kidney disease, where we are taking the data we've gathered here, as well as data from physicians and nephrologists, and we're creating some interventions with patients who are at risk, as well as with providers, primary care providers. This study was funded by CVS Kidney Care. You can read the objective here. The purpose of this research was to assess knowledge of CKD among rural adults in Alabama. And I don't know how familiar you are with CKD, but it's a huge problem nationally, as well as certainly in Alabama and the South in general. 1 in 7 people have CKD. Many of them don't even know it, like 90% don't even realize it. It's not necessarily a disease of minorities or disparate people. It's a disease that can affect everyone, and as you're well aware as nurses, can lead to kidney failure and cardiovascular disease. The diagnosis of CKD is very important, because that's when hopefully the primary care provider is going to say, okay, it's time to go see a nephrologist. We're not sure that's always happening. But albuminuria and then the glomerular filtration rate's really important. I don't know how up to date you are on those aspects, but the whole GFR is an issue, because some providers use a different calculation based on race. So there is a race correction factor that has been a great concern, because many African Americans who've had that used believe that they are diagnosed later with CKD and are not eligible for treatments. And so my understanding is that race correction factor is being eliminated, that they're no longer going to do that. The rationale for using it was that people with dark skin did have a different rate at which their glomeruli filtered. So that was the rationale, but we've moved beyond that now, and that's a good thing. That's a good thing. Certainly it's more common in the elderly, just like everything else. When you get old, things wear out. So the other thing is that many people are asymptomatic in their early stages. And as I mentioned, we met not only with people with or at risk for CKD, but we've also interviewed a lot of people on dialysis. And probably a month or so ago, I interviewed a man who has been on dialysis for 16 years. He does home dialysis. He is 58 years old. So he was diagnosed when he was 42 years old. And when he was younger, he had high blood pressure. And he said, I didn't feel bad. I'd go get checked. I didn't feel bad. They gave me pills to take. I didn't like the way the pills made me feel. Then he went to see the optometrist because he was having trouble with his vision. And the optometrist said, no glasses. You're going to the ER. Your blood pressure's out the roof. He went on dialysis that day, and he's been on dialysis. He said, I wish somebody would have told me that this could happen. I wish somebody would tell me. Now, one of the things we found and this is, I'm sorry, we'll get back to this study, but a lot of the people who were on dialysis, even though they had been seeing a nephrologist for years, did not know they had kidney disease. And this is, you'll see with the knowledge, the kidney knowledge test, it's just amazing to me. So we as nurses have work to do. Diabetes and hypertension, you know the twins, diabetes and hypertension. African Americans with CKD certainly have a higher mortality rate, and it does progress to end-stage renal disease. 5 different stages. nephrologists would like to see these people around stage 3, but a lot of times they're not getting them until late stage 4. And sadly, they're not getting them until some of them end up in the ER going on emergency dialysis. And then it's much more challenging. And the likelihood of being able to get a transplant becomes less. So 71% of these people with ESRD are on dialysis. And you know, that's a whole economic issue as well, because the federal government provides for that as a part of law. And now CMS, I think, is trying to push people more towards home dialysis. Well, we just learned about home care and going to visit people in their homes and taking care of them in their homes. And those of you who've been in rural areas and been to homes to do home health know that dialysis, you know, needs to be a very clean procedure and needs to be very, you know, not have critters around and those kind of things. So that can be very challenging, not to mention the fear that people have they're going to bleed to death by themselves if they have to connect everything. So it's very difficult. So this was a descriptive survey. It was approved by our IRB at the University of Alabama. And it was a convenient sample of people. We identified who were either had or were at risk for CKD. We wanted that baseline. Okay, what do these people know? Do they even know they're at risk? You know, who are they? And this is how we defined at risk, because that's based on the National Kidney Foundation's outcomes for quality initiative, the KDOQI. So obviously hypertension, diabetes, smoking, heart disease, autoimmune disease is also associated with kidney disease, and of course a family history of CKD. So anybody with those things was considered to be at risk, or some people knew they had chronic kidney disease. So we did collect data over 9 months. We collected data in a lot of different places. We went to churches, farmers markets, we went to supermarkets. We posted on, you know, social media, just any place that we could go. We went to health fairs. We went in Alabama, the National Kidney Foundation. Well, the Alabama Kidney Foundation has walks every year in 5 different metropolitan areas. In Alabama, we participated in all of those to collect data. And so we were, it was a lot of work. Okay, so we had 2 instruments. We developed a demographic assessment, and then the 24-item chronic kidney disease knowledge questionnaire. And I don't know if you're familiar with that or not, but the references here for you all. That's at the end. And it's scored by summing all of the correct items. We also asked people as a part of the consent if they were willing to have their primary care provider allow us to see their most recent lab work. And that would be their blood work. Their basically, you know, blood chemistry was what we were looking for. And 139 of the people did allow that. So that was wonderful. We had 529 participants. As I said, 139 gave permission. We did give a $15 gift card for completion of both of those surveys. And that, I think that was appealing to a lot of people, especially in these large, you know, come fill out a questionnaire for 15 minutes and $15. So that was a nice way to get people encouraged. Here you can see the average age, mid-50s, little more than half African American, little, you know, almost 2/3 female. Most of them, more than half, had Medicare or private insurance. A lot of them worked outside the home. You know, that's another issue when people go on dialysis, because their lives are pretty much consumed by the dialysis treatment. 2/3 of the people we surveyed were rural dwellers, and most of them perceived their health as good or fair, which was pretty impressive, I thought. And you can see some more data here. 58.3% had hypertension. And then, you know, some of them and some others had diabetes and heart disease. 17% with a family history of kidney disease. These were not, as I said, it was about 2/3 rural dwellers. The urban dwellers were less likely to have hypertension, but more likely to report that they had had stroke or cancer in the past. Blacks were less likely to report heart disease, but more likely to have diabetes. And the rural dwelling Blacks had higher knowledge scores than any of the white people. I believe, and I can't confirm this, is that there is lots of family history there. They are well aware of what those risk factors are and what, you know, what goes on with chronic kidney disease, because they've seen grandparents and parents and siblings live with that. Okay, urban dwelling whites had higher knowledge than rural dwelling white people, which was interesting. And urban dwelling African Americans had lower knowledge scores than the rural dwelling African Americans. Again, I think that family connection, that community connection plays a big part in that. And higher knowledge scores were associated with the family history of CKD. Worse self-reported health. People who had lower knowledge scores had a lower self-reported health, which does not surprise me. And then the CKD knowledge score, and I'm going to show you the CKD, and it's going to be really hard on here, but okay, so there's a total of 24 questions. The average score was 12.6. So, you know, 50% correct, needs to be better. 32% didn't know that the kidneys clean toxins from the blood, didn't know diabetes was a risk factor, nor hypertension. Half did know that the kidneys maintain blood pressure. So that was good. We've got plenty to work with here. And they knew that water retention was a symptom of CKD. This is the survey, and I apologize. I know it is very difficult. I was hoping it would be bigger, but nearly everybody knew that a person can lead a normal life with one kidney. That was pretty commonly known. They also knew that certain medications can help slow down the worsening of kidney disease. Let's see here. They were not so sure about the bones, keeping the bones healthy. They did not understand that with the phosphate and calcium and all of those things. As far as diagnosis, how you can diagnose kidney disease, nearly everybody knew that a blood test or a urine test, but what people did not realize, and well, I think they may have felt that they had been tricked or something, but a stool test, they thought, well, okay, if it's blood and urine, then maybe you can do it with a stool too. And no, that's not the case. So anyway, they also were pretty aware about the symptoms as far as the nausea and vomiting, less than half, but close to half, loss of appetite, because the people who have CKD or the people who are on dialysis, oh yeah, loss of appetite, you know, the fatigue, the nausea and vomiting associated with that. They're unfortunately very well aware of it. As far as the lab work results, albumin creatinine ratio was higher in women, but that's not unexpected. That's a normal finding. So we need to not try to interpret that in any way. Elevated glucose levels were observed in about 35%. Again, there's that, and I don't know if those people, we don't know if they had diabetes or not. We don't know if it was a fasting blood sugar or not, but if it was over like 130, counted it as elevated. So I'm guessing it was probably supposed to be fasting, but that's a guess. We don't have those data. But using that cutoff, 35% levels, we know there's a connection with the heart disease as well. Rural dwellers who work outside the home had higher cholesterol levels. Any thoughts about that one? Eating out all the time? Could be. I think so. I think you're probably right. Yeah, I thought that was interesting. And the ones who work inside the home or around the home or on the family farm or, you know, in a garden all the time, their eating is probably going to be different. So what are the implications for practice? Why is this important? Well, regular screening for early diagnosis of CKD or any related kinds of risk factors is extremely important. Promotion of self-advocacy, and I know I've talked with some of you about the importance of trying to promote self-advocacy in rural dwellers, just about their general health, because that's so important to have that confidence in saying to the provider, I don't know what you're talking about, or I have a question about this. Because you know that many people, when they go to see their provider, they don't want to bother the doctor. They don't want to take any extra time, and they have to self-advocate. And what I've said to some folks is, I like the tool Ask Me 3. Are y'all familiar with that? The Ask Me 3. You know, what's wrong with me? What do I need to do about it? How's this gonna, you know, what's this gonna do for me? Kind of thing. Great resource. Strongly encourage that. The presentation today about health literacy is just near and dear to my heart, because that use of plain language. I have a husband who has diabetes, hypertension, chronic kidney disease, all the above, and he was a coal miner for 36 years. So y'all understand, and not formally educated well at all. So he has been my plain language challenge, I guess. So, but anyway, it's all good. So promoting that self-advocacy and having people take somebody with them, you know, that's really important, because I would say that 90% of us probably have a question we want to ask our provider when we go that once or twice a year, and we walk back out, and then what? Oops, gosh, I forgot what that was. Okay. Y'all can relate. I appreciate that. It's not just me. So one thing we want to do is to provide some video education in primary care offices. And that's another phase of this project we're working on. Actually, we're working on it right now, creating these short little snippets that can either go on YouTube or they can be on a DVD and put in primary care providers' office. You know, they always have those things that are running all the time. Well, we're trying to do some things, and as far as health literacy and all of that, you know, one really important component is that when people watch a video or see something on TV, they want to see people that look like them. And I've done work with organizational health literacy, and you know, I try to say, if the posters on the wall look like they're 20 years old, the hairstyles are all different, the people don't look the same, you've lost people before they even sit down. So, you know, that's really important. So we're trying to get these videos done now. And anyway, anybody want to volunteer as an actor? Plain language by providers. You know, we're all so proud when we learn all those technical terms, and that's nice. That's good. There's a time and place. But when you're talking to real people, you got to use real language. And you know, real people don't void. Real people pee. So I think that's if you take nothing else away. The other thing that we're working on is a point of care decision-making support for providers that would work in its final stages as well. It will have guidelines, it will have GFR calculations. You know, they can put in the patient data, and there are calculators out there, you know, but to put all of those things together is spectacular. And let me just say, as another aside, if you're ever trying to work with technology, and if you're like me, you don't know anything about it and don't know where to turn, contact the local university and see if they have students. We're working with a student right now who is I think she's part Spanish major, but then she's also in the computer-based honors program. And she's creating all this stuff. And it's just, it's magical to me because we just tell her what we want. She says, yes, we can do that, or no, I can't, And so anyway, it's great. But hopefully that's going to be available in the App Store. We're going to pilot with some primary care providers, some nurse practitioners, and some family medicine residents, we hope. So we're looking forward to that this fall. What are the implications for research? Well, more interventions, test interventions for self-advocacy, connect diabetes and hypertension with CKD so that people realize it. And back to the videos for a minute, one thing that concerns me is, I know all of you occasionally see TV at least, and you've seen all the commercials about, oh, this is the great and wonderful drug that is going to solve the problems of the world. Somehow I want to put a disclaimer in there that don't believe everything you see. Don't believe everything that's on TV. I think people get sucked in by that stuff, just like those Medicare commercials that drive me kind of crazy. But so trying to educate people to not fall for things. Everybody looks so happy, and they're dancing and jumping over at 80 years old and stuff. It's just not real. And then interventions to eliminate that fatalistic attitude about CKD. And I was just talking about that fatalistic attitude of grandma had an amputation. My mother had diabetes and had an amputation. So I'm going to have diabetes and I'm going to have an amputation or kidney disease or whatever. So whatever kind of interventions, culturally appropriate interventions that can eliminate or mitigate that fatalistic attitude, very important. And then we've got work to do to educate health professionals as well. The clear communication, shared decision-making. And I know that's kind of a dirty word to a lot of providers because shared decision-making equals extra time in the view of many providers. But I read a wonderful post today by a physician who says we need to get nurses involved in shared decision-making because if the physicians can't or won't take the time, the nurses are the people who can and should take the time and develop those relationships and learn what those, shared decision-making is just that. Don't come in and tell me that you're going to start me on atorvastatin and then give me a prescription and send me out the door and say you're going to see me in 6 months. Because what am I going to do? If I don't like it, if I don't want to do it, that prescription never gets filled. Or if it does get filled because it's sent electronically, if it gets filled, I may never take it because I didn't have a choice in the matter. And that's what shared decision-making is all about. Identification of risk factors with patients. What are their risk factors? And then the self-advocacy as well. Here's the references. And again, these are all going to be available to you online as well. And there's the one for the CKD knowledge. And we want to acknowledge all the people who helped us. We've worked with graduate students and our program assistant and undergraduate students and the people who helped us to collect data, helped us give us access to be able to collect data. What questions do you have?
Well, I'd like to say thank you because I used to run dialysis clinics in Georgia. So you're speaking the language I lived for a while. And I now live in rural Appalachia, about an hour away.
Yeah.
And still have to deal with, in different cultural aspects, but some of the same similarities. And so I'm really curious on how you think you're going to find a way to get rid of some of these fatalistic, because that, Mama had the sugar, Grandma, Meemaw had the sugar, I got the sugar, my kids are gonna have the sugar. It's God's plan. That's what I get up here. And down there, it was just, this way it's gonna be, all there is to it.
Yeah.
So if you find a magic bullet in order to be able to help us nurses who work with clients who have that throughout this, especially in the Appalachians, I want to know how how you do it.
I don't have any tried and true, but what I know about educating and behavior changes, we have to get the people who the ones we want to change, who they trust.
Right.
If that's the pastor, if that's the barber, that's real big. If that's the librarian, if that's whoever it is. Yeah, if it is their children. See, in the study that the poster's about up there, we had youth groups with this other grant that we had. And part of the reason for having those youth groups was for them to go home and teach their parents how to advocate, and go with their parents or help their grandparents. We did health fairs and everything else. So you got, when your child's saying to you, I don't want this to happen to you. It doesn't have to happen to you. If you can educate that younger generation, then hopefully that's going to help. But you've got to get to the people who can make that change.
Well, here in the Appalachians, it's not going to be the pastor.
Okay,
Right now.
that's okay. That's okay. That's okay. But there's somebody that they go to,
Yeah.
whether it's the beauty shop, the barber shop, whether it's the grocery store. Everybody confides in somebody outside the family. Everybody does. So maybe it's their coworker, maybe it's the neighbor, the neighbor whose grandmother didn't have, the sugar and it's not easy and it's a process. The other thing is you got to accept people where they are.
Oh, absolutely.
And then say, okay, let's think about, what you can do. And are you willing to try? Are you willing to make any changes? And I was saying to BJ earlier, my dad had cholesterol problems, and that was back in the late 80s. Of course, he gave them to me, but anyway, the doctor told him, you got to quit. You got to eat turkey every day. My mother had been dead for years. So he went to the restaurant every day to eat for breakfast. And he said, Felecia, if I got to eat turkey every day in my life, I'd just soon be dead. And I understand that. And I appreciate that. And I'm a big quality of life advocate. I said, look, Dad, if you want to eat bacon and eggs every day for the rest of your life, you go right ahead. It's okay. It's okay. We all make choices.
Right.
There are consequences, but we all make choices. So, I think letting people know that the other thing is with diabetes, everybody thought, oh my goodness, you got the sugar, you're not allowed to eat any sugar the rest of your life.
Oh, yeah.
You'll never be able to have a piece of birthday cake as long as you live.